Nick, and thank you again for organising this wonderful day. We've been looking forward to it for so long, and it's just so wonderful to be full of the excitement of the room. So thank you, everybody, for being here. Okay, so it's a great pleasure to be talking about emerging treatments. That's what we're all here to hear about. This is always a bit of a difficult slot, the first slot after lunch. So we're going to have a bit of an interactive session. I'll save that for later. But stay awake, please, because we're going to require your input. Okay, I have to declare my interest, and no one has funded me, unfortunately, for this talk. So there we go. That's the life of being an OCD researcher, I'm afraid. So what do I aim to cover? Well, I'm going to present some new research investigating emerging treatments for OCD, and I'm going to focus on two very different approaches that do epitomise some of the issues that we've talked about already. So the first study I'm going to show you is a pilot study, a very small study, looking at the feasibility of using a form of non-invasive brain stimulation. It's called direct current stimulation in people with OCD. So that's the first study I'll show you. And the second study is going to be the first time we've applied habit with CBT for OCD to see if using habits can help us challenge OCD itself. And throughout, I'm going to be introducing this concept that we've spoken about already of personalised care for people with OCD. In other words, it's not one size fits all. Different treatments might suit different people, and the secret is going to be to find out how we distinguish, how we stratify or group people so that we can target the right treatment to their form of illness. And then finally, this is the interactive bit, we're going to launch the OCD College, the Orchard OCD College, along with the trial registry, and engage collaboratively in some public engagement in science. Now, those of you who are interested in the neuroscience, we've had a lot of neuroscience this morning, might be interested in this book. I had the honour of editing it with Professor Trevor Robbins. It's only a few years old, and I would say that the findings are still pretty up to date. So if you're interested in understanding the neuroscience background of a lot of what we're talking about, do dip into this book. And we titled it Accelerating Progress because this is a very optimistic field. There's a lot of hope out there. It's moving forward quickly. So I think that's also a very important point to make. In our research, we tend to capitalise on this latent marker model in order to find our new treatment targets in OCD. So we work on the principle that we have the genetic and environmental causes of OCD. We've talked about them this morning. You might be born into a family with a lot of people with OCD, so you're high risk through your genes. Or you might have suffered some trauma or adverse early experience, so that might be a causative factor. So you might target treatments against those. Not so easy to do. We've got the symptoms of OCD there, so that's what you end up with. That's your illness. But in between, we have these hidden markers. And our hypothesis is that these causative factors cause changes in the brain, and Anna Maria was talking about some of those, that result in changes in the way we think. So we might be more inflexible or disinhibited or habit-related. And that results in symptoms. So if we can target our treatments at these problems, we might get a better handle on OCD. So let's start with the thinking changes. How do we find out what the thinking changes of OCD associated with OCD might be? Well, we do these tasks, these games, and we've heard quite a lot about games. We even had rats doing games, so this is just humans performing these games, and we can test various processing skills amongst people and see where people with OCD might differ. And I'd like to commend this very historic paper by my colleague Sam Chamberlain, working with Barbara and Trevor in Cambridge at the time and sitting in our clinic, who did some of the earliest cognitive or thinking testing in people with OCD. And the great advantage of this study, as we've already spoken about, is not only did he use people from the clinic with OCD, but we took their parents or their sons or daughters who didn't have OCD, and we tested them with these tasks against a group of healthy participants. And we found, for example, these cardinal features of thinking errors. The first is that people on a task that gets you to change, to lose a learnt rule and change to a new rule, people got very stuck on the old rule. Once they learnt how to do it a certain way, had great difficulty flexibly shifting to a new way. And here we have the graph. And in the royal blue, so errors, the higher you are on the graph, the worse you perform. And the royal blue column are not the patients with OCD, that's their first-degree relatives. The navy blue are the patients with OCD from my clinic, and the green are the controls. So people with OCD and their first-degree relatives perform much poorer on tests of flexibility. And this was a different task. This was a task of a bit like Anna Maria's motor control task. This was being able to stop a movement once it started. And again, the relatives and the patients were impaired on this task compared to the controls. Now, you wouldn't have known that. It wasn't a question I'd ask in the clinic, are you inflexible, are you impulsive? You know, we'd be talking about OCD. But on a probe like this, these hidden factors can emerge. How do we then, moving on to the brain changes, how might we look for those? Well, we've heard of various measures of various kinds of brain imaging. You can do structural brain imaging, you can do functional brain imaging, you can look at the metabolites, as Trevor was talking about, see the neurochemistry. You can use EEG basically as a form of brain imaging. And putting all that together, simplistically, we've heard already that there's a problem with the top-down cortical control. That's the top bit of your brain. And that just doesn't seem to be governing the brain strongly enough. And we have these deeper parts of the brain, which we call the basal ganglia, which are responsible for generating the movement, sending the electrical currents down to my arms and my legs and so on, coming out of here. And there's probably some kind of imbalance. Either there's too much bottom-up drive to do the compulsions, or there isn't enough control to stop the compulsions, or there's a bit of both. But that seems to be this imbalance model for OCD. Now, of course, the brain isn't just a big blob like that, and we've heard from Himanshu how we've started to understand in much more detail the brain circuitry involved in OCD. Himanshu was talking about deep brain stimulation. I'm going to talk about non-invasive neurostimulation, but I'm just going to remind you of, now I've got a different 3 circuits. It's always the case. My 3 circuits are these parallel circuits controlling reward and mood. So this is, affect is another word for mood, and they're all linked to the Alexander circuits that Himanshu showed us. So this goes from the cortex, so this is all sort of orbitofrontal cortex, through down to the basal ganglia and back, and that controls essentially whether you feel something is worth doing. Is it rewarding enough? Should I actually invest energy in doing something? So it's important in everyday action, but you can imagine if you've got OCD, it's important whether you end up doing your OCD or not. Does it have value? And then the next interlinked circuit is the cognitive control circuit. It's a little bit lateral, a little bit to the side, a little bit further back in the cortex, or still going down into the base of the brain. And that controls action selection. Well, if I want to do it, how do I do it? What would be the best approach to achieving whatever it is I want to do? And then there's the third circuit that interlinks, and all these circuits talk to one another, which is the supplementary motor and motor cortex. We've heard about that as well. And that's, well, if I am going to do it, what is the fine-tuning of doing it? And does this need to be goal-directed? Or if I've done this behaviour and over before, do I need conscious control? Can this just be a habit? And this comes from even further back on the head and goes down. And not only does it use the basal ganglia, but it uses other deep structures as well, including the cerebellum. And so, as I've said, in OCD, we think there just isn't enough top-down control from these cortical bits over the lower, deeper structures. Now, what are those flashes that I've put on the diagram? It's very simplistic, of course, but the flashes, these are the two targets that we use. This is where we inserted our electrodes in the deep brain stimulation study that we heard about just before lunch. We had, and I wonder if this is actually the sweet spot or not, but we had one electrode in this reward circuit, and we had one electrode in a circuit that we think connects to the cognitive control circuit. And they were very effective, as you saw. You saw those Y-box scores going down. Gosh, that was very impressive. But what I'm talking about is these non-invasive stimulation targeting these 3 points, relay stations on these 3 different loops, and targeting each of those loops with either an electric current or a magnet, there have been studies showing some evidence of improvement in OCD. And of course, it's much cheaper and it's much easier and it's much safer to just stimulate from the surface than actually have to put electrodes into the brain. Now, most of those studies, almost all of them, have used a magnet to stimulate the brain. It's called transcranial magnetic stimulation. And if you remember your physics O-level, basically if you put yourself under a magnet, you can generate an electric current if you've got movement going on. And using these magnets, there's evidence that they're pretty safe in OCD. So this is the NICE guideline. Remember, it's old, 2005, but it still governs what we're allowed to do as treatment in the NHS. So the recommendations were there was no major safety concerns, but the evidence on its efficacy is inadequate in quantity and quality. Therefore, this procedure should only be used in the context of research. I'm often called by patients, say, can I have TMS? And I have to tell them. NICE says it's still, if I was running a research study, by all means you could join it, but it still needs to be delivered in research. And research should ideally be in the form of pre-registered, adequately powered randomized controlled trials. So the evidence is accumulating for TMS being effective. We've got a small number of studies, but none of them have really nailed it, particularly for NICE, and they're asking us, they're really calling out for us to do a large-scale, properly powered study, because most of the studies are pretty small and a little questionable. So we responded to the challenge, but we decided, rather than use magnets, which requires sitting in a special centre in a hospital for hours, we were going to move to this transcranial direct current stimulation technique that we've already heard about this morning, which is cheaper, so the NHS would love it, portable, much more convenient and probably safer than TMS as well, because it delivers very, very tiny currents through a little electrode to the brain. So we managed to persuade the NHS to run a small, I put in for a big study, they said, no. We'll fund a feasibility study first. Don't be too ambitious. So, okay, this is what we did. And so we recruited 20 patients with OCD, and then each patient received 20 minutes of stimulation. It was through the cathode, so we think this is inhibitory, turning off, targeting the orbitofrontal cortex, and that was the reward circuit. That was circuit 1 of the 3. And we also targeted the motor circuit, the SMA. We didn't target the cognitive circuit, we just did 2. We thought they were our best chance circuits. And we gave people 2 sets of 20-minute stimulations per day over 2 days. So they got 4 stimulations on 2 consecutive days, and then we left them for 4 weeks, we monitored them over 4 weeks, and then we gave them the other, stimulated the other target. And then another target was done with sham stimulation. Oh, there's sham, where they just got a little buzz, but they didn't actually get the electrical stimulation. They didn't know when they were getting active or inactive stimulation. And the people who rated our patients' outcomes didn't know which treatments were which, and the patients didn't know which treatments were which. And these were our results. First of all, people found it very easy to do. I was worried. I didn't think that people would like to have electrical stimulation to their brain. Patients in our study found it very straightforward. They actually suggested they could do this at home. Why not? You can buy kits similar to this on Amazon for very, very cheaply. I'm not recommending you do it, but there we are. It is being done. It was very safe and well tolerated. We had no serious adverse effects, maybe a little bit of tingling, maybe a little bit of redness on a few occasions, but nothing much at all. Most people thought nothing much was happening. Now, what about OCD? Well, here we have that famous Y-box scale, Yale-Brown Obsessive-compulsive scale, and here we have the days after treatment. So this was at baseline. They're coming in scoring about 25. Remember, for deep brain stimulation, they were scoring about 40. So these are kind of moderately severely ill people. And then by day 3, so the blue is the orbitofrontal target stimulation. They dropped down to less than 20. They're about a 16 probably. They dropped significantly or improved significantly on Y-box. And then over the course of the following 4 weeks, their symptoms gradually crept up because they'd only had 2 days stimulation, and then we followed them up for a month. The SMA target, which is the orange target, didn't do quite so well, and the sham also, remember, you have a placebo effect. You know, just speaking to someone like me will help your OCD, but only temporarily. So there was a placebo effect, but it did look as though there was a signal that orbitofrontal cortex stimulation would work in OCD. We also measured depression on the Montgomery-Åsberg Depression Rating Scale, and that sort of paralleled the OCD symptoms which we might expect. We also, of course, did our cognitive tasks. Here we go. And we used those, the Sam Chamberlain tasks, let's call them. We did the extra-dimensional set shift task and the stop signal, so that's for flexibility, and we did the stop signal task, that's for inhibition and impulse control. And in this case, a taller column means improvement in. This is how well you did the task after stimulation compared to before stimulation. And on both sites, if you stimulated either the orbitofrontal or the SMA, there was an improvement in that flexibility score, whereas there was no effect at all on the motor control. So in summary, non-invasive neurostimulation using this new technique, which would be easy and able to scale up. Remember, OCD is very common, so we need treatments that people can use at large scale. We're targeting these corticostriatal circuits, but not with deep brain stimulation now, with a non-invasive technique. We found target-specific effects, so orbitofrontal seemed to improve OCD and mood. SMA didn't do quite so well in a tiny study. But there was also an early improvement. Remember, those symptoms changed by day 3. We heard already from Ilenia, if you're on an SSRI, it'll work, probably, but it'll take you weeks to get well. So maybe a little, starting to think, maybe we could start people off as they're on their trajectory to get well on SSRI, give them a little bit of tDCS as a sort of adjunct at the start. Sort of all these ideas are generating in our mind. But what we also saw, there was an improvement in flexible thinking. And we in the clinic find inflexible thinking a real challenge to treatment, both CBT and medication. So if we had a treatment that targeted inflexibility, that could be very clinically useful. So that might be the kind of person, if we're starting to personalise treatment, where this treatment may have an edge over other treatments. The second kind of treatment I was going to talk about is a psychological form of treatment. And this goes back to a conversation we've had earlier this morning. And the question is OCD a disorder of habit? We've heard that the brain circuits that are affected in OCD also are important for the development of normal, healthy habits. We also hear from patients that a lot of their OCD, particularly after they've had it for some time, feels like a habit. They've no idea why they're doing it. They're at the sink and they're doing hand-washing rituals and they don't know why. It doesn't seem to make any sense, but they just can't stop. And certainly on certain of these cognitive tasks that look at information processing, there looks to be a bias toward responding in a more habitual way as opposed to in a purposeful way in general. And a lot of work was done by Claire Gillan, working with Trevor at Cambridge University, also sitting in our clinic, trying to unpick using brain imaging and cognitive tasks this question of whether people with OCD do have a disrupted balance between habit and goal-directed control. And we heard from this morning that picture seems to be crystallizing in favor of that idea. And this may underpin the drive to perform compulsions in some people. Now, is it everybody? Is it just after you've had your OCD for a long time? I mean, there's a lot of unanswered questions. Nevertheless, targeting habit mechanisms could be another different treatment approach for OCD. So this leads on to the second study I'll show you, and this was completely unfunded. I'm very grateful to Hertfordshire Partnership Foundation Trust, who supported this study by allowing us all to do it during work time. Anna Maria was our blinded rater, and she's writing up the paper at the moment, and she also did EEGs on these patients, but I'm not going to be showing the EEG data today, but simply talk you through the trial. We took 45 patients with OCD attending routine clinics. Now, some of them were in the specialist clinics, some were in IAPTs, improving access to psychological therapist treatment. So it was a range of severities, but not particularly severely ill. And we randomly allocated them to either our experimental treatment, and I'll tell you what that is in a moment, but it's exposure response prevention augmented with a habit, or as the gold standard treatment, exposure and response prevention, supervised by an expert in CBT for OCD. So what was this augmented? How did we use habit? Well, it's based on the principle of habit reversal therapy for hair pulling disorder. And if you have hair pulling disorder, it's a very behavioural problem. If you sit in a particular chair or doing a particular thing, you get this strong urge to pull your hair. And the habit reversal therapy works by giving you something else to do with the same muscles. So identify where the hair pulling happens, and then have something at hand that you can do instead of the hair pulling to break the stimulus response, to break the urge in that particular area to do the hair pulling, because you're doing something different, and it allows the compulsion to pull your hair to extinguish and disappear. So we treated compulsions as though they were habits in a way, and we trained patients on what we called a non-pathological, so it wasn't harmful, a six movement finger sequence where they had to learn how to move. It was a sequence of 6 movements, and they had to learn with their fingers to practice it, and it had to become automatic. And the idea was that during exposure and response prevention, when they were exposed to the cue that generates the urge to do the compulsion, be it washing or checking, whatever, they practice instead their habit, their finger movement, and that should help them extinguish the urge to do the compulsion. Now, of course, if you're going to apply a habit, you've got to learn the habit first. You've got to reach automaticity. So people randomised to the experimental arm had a 2-phase treatment. They first had 6 weeks of habit training, where they learnt this finger sequence, and we tested them very rigorously to make sure they did learn it, and they did. And then in the second phase, we incorporated it into the exposure and response prevention. And again, we had blinded raters who didn't know if they were in this treatment or this treatment. Now, the first phase, and again, this is a limitation of the study, because this is a very surprising result that we found. The first phase was simply learning the habit. So it was a lot of, if any of you have practiced the piano, it was like practicing the piano, the world's most boring scale, for up to 6 weeks. Imagine having to do it. Doesn't sound fun, does it? What very much surprised us was that on average, not everybody, but on average, there was improvement in OCD just in the first 6 weeks of training. Now, where we missed a trick, we didn't have a control for training in our other experimental control arm. because we never thought, it just didn't occur to us that there might be a therapeutic effect of just learning the habit, but there was. It meant, so the people, this is the next part, the 12 weeks of CBT, either with your habit or not. So the control treatment is the red, that's standard ERP, and our experimental treatment is turquoise. And people are on medication as well, that's these pills, not everyone, but mostly, so it's sort of augmenting medication. Both groups, this is the beginning of therapy. Our experimental group already started at a lower baseline because they'd already done the training. But both groups improved over the course of the treatment, and there was no significant difference at the end of the treatment between the two groups. So we hadn't got an astonishingly better improvement with the habit therapy, but it was well tolerated. There was no particular increase in dropout or side effect rates, and people ended up roughly the same. But what we found, which was very interesting, we thought, was this early improvement. Again, early improvement in OCD. We don't have treatments that work early. Simply by learning a finger movement, maybe stimulating that circuit in the brain. What's going on there? Well, and Paula Banker, whose name we've already heard today, who's now working in Spain, she extended our group of patients. So these are our patients in pink whose OCD improved when they were doing simply the habit training. And we recruited a few more to just get the numbers a little bit bigger. And the darker purple are people with OCD who did the habit training, but their OCD didn't improve during training, because not everybody, it didn't work for everybody. And here we have, in the very pale purple, we have a control group who's also learning this automatic sequence. And we gave them a task, which was to see if they preferred doing their familiar sequence to basically any other little movement that was much less effortful than having to remember a certain sequence. And what we found was there was a difference in preference, and the people who'd done well on habit training and their OCD had improved were also people who much preferred to perform their habitual sequence, even though it was more complicated and effortful than just any other three-finger movement. So they seemed to like something familiar that seemed to distinguish them from the people who didn't do well in habit training. So in summary, for our second, again, very small study, very early days, it's the first randomized feasibility trial we've called it habit augmented ERP, because is it really habit reversal? I'm not entirely sure. So we're being very conservative in what we say. ERP and habit was well tolerated, acceptable, potentially efficacious. Habit training, remember, not yet control, so we probably need to do a control trial. In the absence of any therapy, they were just practicing a habit, was associated with early improvement in OCD, and those who showed a preference for familiarity seemed to benefit from that. So certainly it occurs to us that there's a role for investigating these very behavioural forms of therapy. There wasn't much cognition involved in learning the habit. And those with stronger habitual tendencies may benefit preferentially from interventions targeting the habit system, which challenges us back in the scientific community to get some really good habit scales, habit measures that we could maybe apply in a clinical setting, because we're not very good at measuring habit tendency yet. So in conclusion, before we get on to our interactive bit, transcranial direct current stimulation shows promise in OCD. The mechanism of effect remains to be established, but it may work by improving inflexible thinking. That may be one way it's working. Habit-augmented therapy is feasible for patients with OCD and may work best for those with increased habitual tendencies. By expanding the repertoire, and this is a theme that we've already heard this morning, Nick was talking about that, we need a load of different treatments, a menu of treatments. But if we could expand the repertoire of mechanisms and therapeutic interventions, we can then increase the scope for more personalised approaches. If you've only got CBT and SSRI, what could you personalise? There aren't any options. We need to get those options on the table. And they may be applicable not only to OCD, but to a broader group of OCD and related disorders. Remember, OCD now fits in that family of obsessive-compulsive related disorders. We've heard about body dysmorphic disorder, hoarding disorder. I was speaking to Sharon Moraine at lunchtime. There's almost nothing out there for hoarding disorder, and so on and so on. And to succeed, then, what is our task here today? Well, we need to engage in more collaborative research, and we in the scientific community need to engage with you, with people with lived experience, to fully validate not only these interesting emerging findings, but new findings that will come only from the kind of discourse that we're having today. So what are we doing in Orchard? Well, the first thing that we did, we set this up over a year ago now, and we've already heard from Nick, and we're going to have a session on it this afternoon. We've set up the Orchard OCD registry, and this is a dating agency between scientists interested in OCD and people with lived experience, or maybe like a travel agency, go on a journey. It gives you information. If you register on the site, you will find out all those studies that are going on in your area of interest, if you've got OCD, in OCD, and if you've got a particular kind of OCD or a particular desire to be in a particular study, you can see if that's going on, and you can be given the information of the researcher and contact them and enroll in the study. So that's one way of actually moving things forward. But we're also setting up an Orchard OCD college, because there are a number of disparate groups researching OCD in the UK, and we tend to work together, but we haven't actually had an umbrella organisation that allows us to network as effectively as we can. So there's strength in numbers. So today we are launching the Orchard OCD College. We're going to have our first in-person meeting of all the scientists after today's families meeting. Our goal is to apply research to advance treatment development for OCD. And so many of the people in this room are going to be part of this sort of scientific college. But we're very interested, or not only but, and we are very interested in public engagement. We think the key to success is to engage with people with lived experience. So we're gonna talk about that later this afternoon, but as a little taster, we're going to do this Slido test. So those of you with a mobile phone, please could you join our public engagement in research exercise. As you've heard, we're submitting a grant application, it's competitive, to the NHS to see if we can take forward our non-invasive neurostimulation project, see if we can get funded for it. So part of that, we have to engage with public and hear their views as to whether they think that's going to be useful or not. So here we have the first question. So I've talked to you about what we know about transcranial direct current stimulation. So the question for public engagement is, what do you think about further research into tDCS for OCD? And we have 4 options. I support a clinical trial. I think it's interesting, but I have concerns. I don't think I can endorse the first. I really don't support further research into this, or I'm not sure. So could you, those of you who are able, endorse, tick one of those boxes, and then in real time, if my technical crew are on top, yes, I'm getting the nod, we should see your results. 35, come on guys, there's about 100 in the room.
I'll reveal the results when we get to 50.
So we've got to get to 50. Come on, we're staying here till 50. Let's get... We're at 45. 5 more to go.
Can we get there? I'm not sure.
Yeah, people are still logging in, turning on their phones.
We've got to 40, so that's 47 votes.
47, but here we are, 47 votes, 89. Will we agree as a group that 47 votes was enough to take this result? 90%? Okay, so there we are. So where's the other? 6% not sure, and 4% have concerns for clinical trial. Brilliant. This is what I like to see, because that means more discussion needs to go on, and that's why it's very important to have these sessions and these meetings. And this leads me in very nicely to the next question. Don't think you're let off the hook now. Now you've got the hang of it. Question 2. Orchard, and now we have our college, plans to organise a scientific workshop next year, bringing together people with lived experience and scientists to focus on solutions to the challenge of better treatments for OCD. We want to hear what you want us to research. We're not going to come along with our preconceived plans. What do you want us to do? What do you think about this? Okay, it's an excellent idea. It's a great idea, but I couldn't attend, but I'd like to be involved. I'm not sure yet. Not for me. Okay, come on, guys. We can get 47.
We're over 50 already.
We're over 50. People are more confident in answering this one, obviously. So, again, a nice spread, but now 92%. So really a resounding endorsement of these questions. So I'm so pleased. Now there is just one final question. And that's because you can get 3 free questions on Slido. So that's why there's the third one. Now, I'm going to give you just a few seconds longer to answer this, because this is a bit of free text. Now, we don't want an essay. A sentence or two, or anything you want to say, do write it down, and we're going to have a look at it as I just conclude my talk. But what are your main priorities for OCD research? And they will just come up on this screen as I simply go back and move to my final slide, which is to thank everyone who's worked with me on the sort of work we've been talking about today. Unfortunately, for reasons of confidentiality, I can't put the faces of my patient participants, my people with lived experience yet. But you can see through a formatting issue, there's plenty of space on the outside of this slide for more faces to join me. So I'm hoping at the end of our workshop next year that we'll fully populate this slide with even more networked researchers. So thank you. I think I'll stop there, but just run through some of these answers with you, because I think we ought to, is there a way of saving these answers?
I've got them all, yeah.
So we will save these, and these will become a focus for the workshop. Personalised treatment, personalised using imaging, increasing the options for children, treatment resistant, loads and loads. We will.
The biggest category is treatment. There's a lot of discussion about personalised treatment. So most people want to hear about more treatments. There's a lot of discussion of more treatment types. There's definitely some interest in more research on therapy and personalised treatments. So you can see everyone, and please continue submitting your answers. We'll look at them all.
So thank you very much. Thank you, Nick.